Yes, today I will discuss complication also. So, hysteroscopy, by definition, it's a minimally invasive procedure which is used to view inside the uterus through a telescope-like device which is called hysteroscope. This was first invented in Germany and it was performed by 1865 by Pantolini. Pantolini was a male gynecologist who has performed with the simple lenses, because 1865 there was no any camera, no any light source, no TV. So they have two lenses incorporated together, and he has tried to view inside the uterus with the naked eye. 1869, first diagnostic hysteroscopy was performed, and 2 years later, in 1871, first operative procedure, both were performed by Pantolini. Today we have a lot of invention, a lot of new advancement in hysteroscopy. One of them is Versascope. Versascope is a 1.8 mm hysteroscope, and it has this sheath, and with the sheath it is 2.2 mm. So even in the nulliparous woman, without dilatation, you can introduce this Versascope. And nowadays 4K camera with the high definition, you can have a very good view in hysteroscopy. In the uterus, it's like a collapsed air dome like cavity. It is necessary to fill up with the fluid, either with liquid or gas. And you need to fill up under pressure. In hysteroscopy, you don't need much pressure. Just you can hang up a bottle, and with the gravity itself, bladder will distend. But uterus is a tight, collapsed air dome like cavity, which needs very much hard manual distension. Initially carbon dioxide was also used, but now different fluids are used, which I will discuss later, that what fluids are used. Diagnostic hysteroscopy you can do in office setting, in OPD also can be performed, especially if you have a Versascope, because you don't need any dilatation. Only 45 mm is sufficient. Dilatation means cervical dilatation is not required. But for complex operative procedure, you need operating room setting, because patient need anesthesia, either spinal or GA you can use. Indication. Most common indication is infertility. That's why I have shown you that many gynecologists, they say hysteroscope is my stethoscope. So 85% of all the hysteroscopy is done for infertility, to rule out almost all uterine causes of infertility. These are the most common indications. Evaluation of unexplained uterine bleeding in pre or post-menopausal patient. Diagnosis of hysteroscopic removal of suspected submucous leiomyoma or endometrial polyp. Location and retrieval of the lost IUCD. Exploration of endocervical canal, internal cervical os, uterine cavity in patient with repeated miscarriage. Evaluation of the patient with failed first trimester elective abortion and transcervical division of the small uterine septi. These are the most common indications, operative indication after diagnostic. After diagnostic, these are other most common operative indications of hysteroscopy. But these are not the only. There are many things which can be, for any purpose you can do hysteroscopy. Operating room setup. Patient should be in the lithotomy position. You will sit in between the leg. Monitor should be placed towards the shoulder, either shoulder, and level of the vagina should be at the level of your elbow. So table should be up. This is how you will perform. You need Y channel. The Y channel is required for introducing glycine or normal saline, whatever you are performing. You need 2 assistants either side to help you. Pelvicoscopy. Diagnostic laparoscopy plus hysteroscopy is called pelvicoscopy. Technically, this is the correct term. But many gynecologists they write histolap. That is okay, but actual correct scientific term is pelvicoscopy. If you are doing pelvicoscopy, then laparoscope should be introduced first, and under vision of laparoscope you should introduce hysteroscope. That has many advantages. First advantage, that you can rule out any pelvic pathology. You can rule out if the patient has, suppose, severe endometriosis, severe adhesion, the adhesion of sigmoid, adhesion of the ovary, you can find it out. Another advantage is that you know that uterus is retroverted or anteverted, and accordingly you can do the dilatation by Hager dilator. So you know that you are not perforating. But there is a problem. Problem is that finding out the cervix is difficult once the pneumoperitoneum is created, because by pneumoperitoneum anterior and posterior fornix is pressed. So vaginal orifice is collapsed, and then if you put a Sims speculum, it will not be possible to visualize the cervix. So that's why many gynecologists they hold hysteroscope first and then they put the laparoscope. But that is not ideal. What you do, if you have a problem of visualizing the cervix, then transiently for a few minutes you can deflate the abdomen, keeping the laparoscope in the position, and then catch it, put Hager, and then again distend it. But laparoscope must be first introduced, and under vision of laparoscope, hysteroscope should be introduced, so that you are safe, you will not perforate. But if you have to perform surgery, then after access, we should must perform the hysteroscopic procedure. Like you have a 2 myoma. One is submucous, another is intramural. Then you should never ever perform laparoscopic myomectomy first. Because after laparoscopic myomectomy, then if you will try to do hysteroscopic myomectomy, it is impossible, because uterus will perforate. So first you do hysteroscopic resection, and after that you do the laparoscopic myomectomy. So what does it mean? That access laparoscope first, but after access resection hysteroscope first. Any resection of the laparoscope should not be done, because uterus will become weak, and due to high pressure of the pneumoperitoneum, this hysteroscopic insufflation of 150 millimeter to 180 millimeter, uterus will rupture. So this is a small precaution should be taken during pelvicoscopy. Now equipment. Most common equipment is 30-degree 4 mm hysteroscope. That is must, because 0 degree you cannot use. If you use 0 degree, it will be a problem, because 0 degree cannot show you the ostia. It will be difficult to visualize. So 30 degree is necessary, because if you use 0 degree, it will show you in front, and after that if you will try to move it, suppose to the right side, entire uterus will move together. Left side, entire uterus will move together, because it is stuck with the cervical canal. But if you have a 30 degree, बाबू थोड़ा इसको नज़दीक कर देना. If you will turn it to the right, it will show you left ostia. Your left is patient right. And if you will turn it left, you will see right side. That will be left ostia of the patient. So 30 degree is necessary. Some people they use 17 degree also, but 30 degree is must. This is 30 degree telescope which you can use. So this is equipment is required. Mostly standard hysteroscope is 4 mm 30 degree, and over that you have to use sheath. Now there are some mini hysteroscope that is 1.8 mm. That is called office hysteroscope. And there are some micro hysteroscope which is only 80 micron and which can show you 150 magnification. That has advantage that even the cytoplasm and nuclei of the endometrial linings you can visualize. But that is used by embryologists to check the different type of proliferation of endometrium. That is not used by us. Generally, our work is only a standard hysteroscope and mini hysteroscope. Micro is not used by surgery, for surgery purpose. So telescope is 4 mm and 30 degree. This is your hysteroscope. This is called eyepiece. This is called object lens, and this is called light post. And every company is making, Stars, Olympus, all is making. The good thing about it is any company camera can fit in any hysteroscope, and any light source can fit in any hysteroscope. Now resectoscope. Hysteroscope has different type of sheath. The first sheath is single channel sheath. This is single channel. You have only one channel. It doesn't have fluid exit. It has only fluid input. And there is a line here, and two lines are there which should be together parallel. It should not be away from each other, like here it is away from each other. So you will bring it parallel to each other, and there is one line in telescope here. So all the three lines should be parallel, and then you rotate to the clockwise, it is locked. Now it won't come out. It is locked. To remove it, again bring both the line parallel and it will be out. So this is universal. You go and rotate it and it is locked. This is single channel sheath. After that, you have double channel sheath. This is double channel. In double channel sheath, similarly here also you have two lines. Both the line here, one line here, and one here, it is attached parallel, and then again rotate. Now here fluid input and fluid output is away. And always remember how you will know which one is fluid in and which one is fluid out. Pardon? No, arrow mark is not always there. If it is there, it's good. Otherwise, towards you is irrigation, and away from you is output, that is the suction. Remember, some people you say up and down. No up and down. I can put both up and I can put both down. So it is not. Away from you is going away. That means exit. And towards you is entry. So this is input, this is output. So it has two channels. And that will, here also you have the same hysteroscope will be used. After that you have 4 channels. This is 4 channel. 4 channel has one channel for hysteroscope, which you will introduce like that. Here also same way, all the 3 lines should be and rotate it clockwise. One channel for fluid in, other channel for fluid out, and one channel for instrumentation, and one channel for telescope. So in this you have different size of instrument. These all are instrument. You have scissors, you have biopsy forceps, you have the graspers, you have different flexible instruments. These all are instruments. And these instruments I can introduce it. How? By this channel. This is working channel and this instrument is in. And suppose I have Asherman, here the scissors, and with the scissors I can cut the, see this is scissors opening the jaw, here I am opening the jaw, and I can cut the Asherman with these scissors. So there are different flexible instruments which is used. So this is called 4 channel sheath. Now the last one is resectoscope. This is resectoscope. Resectoscope I will discuss later part of the lecture. I will demonstrate you how to assemble the resectoscope and how to do operative by resectoscope. So this is the different channel, resectoscope. Resectoscope is the same instrument which is used by the urologist to doing the prostate surgery. 50 years ago they have started it, and same resectoscope now you are using for hysteroscopy. First it was started by urologists. There is no separate resectoscope for urology and no separate hysteroscope for gynecology. It is same. It has roller ball, loop wire, Collins knife. These are the different instruments in resectoscope. So resectoscope is very important for hysteroscopy. Let me demonstrate only. So this is resectoscope. Resectoscope has 5 things assembled together. So I am opening it here, and this is called working element. This is called working element. It has active and passive, 2 type of working element. This is the electrode, and you have a different type of electrode, loop electrode, Collins knife, roller ball, a straight knife. These are the different type of electrodes which is available. After that, you have one inner sheath and this is outer sheath. And the last part is telescope. Telescope is same here also, 4 mm, 30 degree telescope. So 1, 2, 3, 4 and 5. These are the 5 components of resectoscope: working element, telescope, inner sheath, outer sheath and electrode. These are the 5 components which is assembled together to make resectoscope. So let us assemble now. First you will take working element. This is working element. Working element is of different type, active and passive. After that there is a knob here. You will press this knob. There is a knob here. And then you will drop the electrode. I am dropping the electrode. Electrode is dropped and it is, once it has entered inside, after that you will fix it. it is fixed, and you will check that it is moving. Yes, see, it is moving. This is moving. So electrode is attached with the working element, and check it by like this. Remember, without pressing this knob, don't try to push the electrode, it will break. After that, you will take inner sheath. This is inner sheath. Inner sheath has two work. One is it has a ceramic tip that create insulation, and another work is fluid input. So I am attaching this inner sheath and locked. Here is the lock for the inner sheath, this lock. You know, anything you rotate clockwise it is lock. Anything you rotate anti-clock it open. It's a universal rule. And good thing it won't go other way. If you try to go other way, it will not fit. After that, this is outer sheath. Outer sheath has two work. One is suction, means a fluid exit, and another is it act as a cannula. So this is outer sheath attached, and again I will rotate clockwise. This is also locked. And the last you will introduce the telescope. Here the telescope. And again here there are two lines, and rotate clockwise, it is locked. And now all assembled together is called resectoscope. See, this electrode is coming in and out, in and out, in and out, and you can go and zzz, cut, zzz, cut, zzz, cut, and here you will attach the current. This is for electrosurgery, to attach the electrode, and this you can use for electrode. And minimum 80 to 100 wattage current is required here, because you are working underwater. So 30-40 watt will not work. You need minimum wattage that. So this is done, and this is called resectoscope. And camera will attach here, CCD. And CCD always should be held like how we hold in laparoscope, and then this has to be rotated. Remember, entire CCD should never be rotated, and this way you will do resection. So this is resectoscope, how you perform it. So this is the same resectoscope which was used by the urologist. If you don't have, you ask your urologist, he will give you. This is resectoscope which we have just seen right now, the video. You see assembled one, completely assembled. And these are the 5 components. What is this? Telescope. What is this? Outer sheath. What is this? Inner sheath. What is this? Working element. And what is this? Electrode. Electrodes are Collins knife, a straight ball, loop electrode, a straight knife, roller ball, different type. So how you will do? First you will take this working element and attach the electrode. This is electrode. It is fixed. And it should be fully fixed, it should not be loose, otherwise after putting outer sheath it is not possible to fix it. And here we can see this is the attachment of monopolar. These are monopolar instrument, and here it is attached. And this end will go to your generator. So this is complete resectoscope, and you will hold it. This is the way to hold. One finger should be here, and these 2 fingers should be here, and thumb should be on the back. This is the way to hold. This is for index finger. This hole is for these 2 fingers, and thumb is on the back hole. and this is how you have to move the thumb. Hook, look and cook. You should never activate in open circuit. Go, hook it, zzz, and then cut. Again you go, myomectomy always distal to proximal. In septate uterus, of course, proximal to distal. So, this is how you will introduce first the electrode to the working element. After that, you will push the inner sheath. This is inner sheath, and rotate clockwise, it is locked. Inner sheath has two purposes. One is at the tip, there is a ceramic tip which acts as an insulation. Tip has ceramic material, and another advantage is that it acts as a fluid input here. You will attach fluid input. In this channel, you will attach Lear lock, and that has a fluid input. Y channel, you should not use saline set. Saline set will decrease your pressure. Pressure will not build up. So, you need Y channel, and you need different type of pump. Easiest, if you don't have anything, at least you should have this Medex pump. This is Medex pump. It is by Medex company, and it has a hair meter, and this is red color. And it has inside, you can wrap the bottle. Here we have a normal saline bottle, and you will wrap it like that, and this will hang, and this is called Medex pump. And there is a pump here, you will put the pressure, and if your pressure is more than the desired, it has a safety lock, it will release, because excessive pressure can create vasovagal shock, patient may collapse. So, this is to attach with the Medex pump or endomet or hystromet. There are different type of irrigation machines. Some people, they directly put in the bottle and they have a needle and pump to push the gas in the bottle, but that is not a good technique. So, this is now outer sheath. And outer sheath, as I told you, what is the function of this? First is suction, means fluid exit. Another function is it acts as a cannula. What do I mean it acts as a cannula? I will tell you. Once you have started a section, and suppose due to any reason you have to remove it, then you are not supposed to remove everything. What you do, open it and remove this only. Never remove the outer sheath and change the working element. Suppose you want to, here this is loop electrode, now you want runner ball because bleeding has started, you want fulguration. Then you change the, or clean it. But this you should not remove. This acts as a cannula. What is the purpose of cannula in laparoscopy? Which you say trocar, but word trocar is wrong. Trocar, yes. Purpose is that it will act as a port. What is the meaning of port? Port means pathway of entry and exit, just like a seaport or airport. Port means pathway of in and out. So, this is your cannula act as a port. So, you should never remove this cannula often. It should be removed at the end of operative hysteroscopy. And suppose I have done some resection, then this is called Medex pump. Sorry, Ehrlich evacuated. Medex pump was there. This is called Ehrlich evacuated. And you will attach this Ehrlich evacuated and then you pump it like this. And what it will do, it will shuck all the cut pieces into this. And it has a filter which you can send for histopathology also. So, this is called Ehrlich evacuator. Some Ehrlich evacuators are like a syringe, that also is there. So, that is why it is fitting into this outer sheath. So, outer sheath should never be removed often. Otherwise, what will happen? Your cervical opening will become loose, and then all the gas will keep on leaking. In animal dissection, you might have felt that if 2-3 times your cannula comes out, after that it becomes loose and gas keep on leaking. You have to apply one Ellis forceps by the side of the port. So that's why whenever you take the instrument out, always you should, one hand you should hold the cannula, then take the instrument out. So same way here also, if you have to perform, you should not take outer sheath often out. And suppose sometime what happened, that your outer sheath is loose and gas is leaking, fluid is leaking, then what you will do? What you should do, you should take a Rodder's knot or Mishra's knot and keep the outer sheath and tie around the cervix and tight it by knot pusher, your leak will stop. So you will tight it around the outer sheath. So it should not be loose, because if it is leaking, then you will not get sufficient pressure, and then uterus will not. One of the biggest problem of the beginners is not getting the distension, because either they overdilate or their cannula is loose. So this is outer sheath. And after telescope, telescope is the last. So how to assemble? First you should put electrode into the working element, then you put inner sheath, then you put outer sheath, and then you put the telescope and lock it. And now it is ready to operate. So this is hysteroscope. Now I have a question, that what this hysteroscope cannot do. First, what single channel cannot do? Single channel only can diagnose any pathology like myoma, polyps, and different phase of endometrial cycle you can diagnose, proliferative phase, secretory phase, am I right? And you can do these things. But after seeing, nothing you can do. You cannot do any polypectomy, you cannot cut any Esserman, you cannot do any cannulation, chromotubation, these things you cannot do. And you cannot take even a biopsy. So it is only diagnostic, after that nothing is possible. But why we use it? Because it is 5 mm. So easily it enters. Once you have diagnosed it, after that you put the 4-channel sheath. 4-channel sheath has 7 to 8 mm. 7 mm is also available. So with that you can do simple operative procedures. How? Some flimsy adhesion with the scissors you can cut. You can put a ureteric catheter to do chromotubation. Chromotubation means directly into the tube you can inject the methylene blue. There are Cook's tubal dilatation device. Cook's is making cannulation for tube to open the proximal tubal obstruction. Cook's system, it is available in the market, which you can buy. So this you can use for dilatation. So if you will see Cook's hysteroscopic dilators, this is available. This is Cook's Medical. They are making beautiful instruments for opening the obstruction of the tube. So this is different making the instruments. This is Cook's Medical and you can buy from them. This is dilator set. So they have serial dilatation, different Frenches, 6 French, 7 French, and this is dilator set here. And you will introduce it and then you will dilate it. So this is for hysteroscopy, you can use it. But the problem is that you need channel 4 channel, then only you can use. Now, biopsy also you can take with the biopsy forceps with the 4 channel, but you cannot do any resection. You cannot use current. If you want to use current, you have to use resectoscope. With the resectoscope, you cannot do any diagnosis. You cannot take biopsy because resectoscope doesn't have any channel for instrumentation. You cannot put a seizures. You can only use electrode. That's why name is resectoscope. It only can do the resection, nothing else. If you want to biopsy resected tissue, you have to collect into the ileal evacuator and then filter it and then send for biopsy. Because any seizures or grasper or forceps, resectoscope cannot take. So there is no any diagnostic advantage. That's why the name is resectoscope. But that is only required if you have a pathology which need current. Like Asherman, you don't need resectoscope. I can cut with the seizures. But if you have a submucous myoma, I need resectoscope. So all these channels you have to buy together. Every channel has its own importance. If I have to do only diagnostic, why should I put 4 channel? Unnecessarily over dilatation, why should I do? So this is important. And now lastly this resectoscope. Access, and here you will see many people they do by naked eye, many people they do by camera. You will dilate it. If patient is multipara, you don't need any dilatation. You put the hysteroscope at the tip and with the fluid you can dilate. But if it is patient is nulliparous, then mesoprost 2 to 4 hours before the procedure, 2 to 400 microgram, wrap in a small sponge and put into posterior fornix, not in the only in the vagina. Nurse should be trained, them posterior fornix, it should must touch the cervix. Sometimes they just put it outside, come out. There is no benefit. It should be completely go to, and it should not be dry gauze piece. It should be moist, wet gauze piece into the posterior fornix. Now coming to distending media. When hysteroscopy was started, then the first distending media which was used by CO2. Still many of the gynecologists they use CO2 for diagnostic hysteroscopy. CO2 is good. What are the advantages of CO2? We have already read in laparoscopy. One of the biggest advantages it is highly absorbable. Another it is anti-compressible. Another it creates means acidic environment, so it is anti-infective. Easily you can buy and cheaper. So, but it is not very good for operative. And for diagnostic also it is good for flash hysteroscopy, means hysteroscopy should not continue for more than 5 minutes. Because if you keep on doing hysteroscopy diagnostic for half an hour, patient will get very bad pneumoperitoneum. Because some gas will leak through the fimbria, and if it is more than 1 liter CO2 in the abdomen, patient will start a discomfort, shoulder tip pain, because the CO2 will start irritating the diaphragm and patient will have difficulty in breathing because it will press the diaphragm. Now you might have to put a Veress needle in the Palmer's point to take those gas out. So you have to do faster. Another problem of diagnostic hysteroscopy by CO2 is that you cannot do operative. Because if you use current, then it will smoke out your lens. In the fluid environment, it won't smoke out, because smoke will not produce in the fluid. Why? under fluid temperature can never increase more than 100. This is rule, that as long as one drop of fluid is also present, the temperature cannot go more than 100. If the water is present, temperature does not go more than 100, because at 100 water evaporates. So there will be no burn, but here there will be burn, and in this burn a smoke will be produced. Another drawback of CO2 is that if your pressure is excessive and you are doing operative, there is a chances of air embolism, because CO2 is safe up to what? Up to 2 liter per minute. But if more than 2 liter per minute CO2 enters into any vein, even CO2 can create air embolism. So that is why it is only for simple diagnostic. After that, gynecologists they started developing the another fluid, dextran 70, low viscosity media like normal saline 5%, dextrose 10% and dextran 4%. Dextrose and dextran is very good for diagnostic, but for operative there is a problem. The problem is if you are doing laparoscopy alone, then it is good that at the end of the procedure whatever dextrose has collected into the cul-de-sac you can suck out. But if you are doing hysteroscopy alone, operative hysteroscopy alone, like TCRE or polypectomy or myomectomy, and then if you will use dextrose, and suppose 500 ml dextrose is collected into the pelvis, then what to do about that? Nothing, because we do not have a laparoscope, we are doing hysteroscopy alone. Then what will happen? That dextrose will act as a culture medium for bacteria to grow, and it can exacerbate the PID. So this is also not very good. Normal saline has a problem. It cannot be used if you are using monopolar, because normal saline is a very good conductor of electricity. It will take the current of the monopolar and it will disperse to the abdominal wall. So again there will be problem. So that is why most of the gynecologists now, for diagnostic they use normal saline, and for operative they use glycine. Normal saline for diagnostic no problem, because even if you are using half an hour to do normal saline, and suppose 1 liter normal saline is in the abdomen, eventually it will be absorbed, because normal saline can never aggravate any PID. Any bacteria cannot take as a culture medium normal saline to grow. But for operative, normal saline is not possible. So you have to use glycine. Glycine has many advantages. It does not react. It is a natural amino acid. It prevents clot formation, inhibit ionization, and only side effect is hyponatremia. Does not react, because glycine is already present as an essential amino acid in our blood. So human cannot survive if they have the allergy with the glycine, because glycine is essential amino acid, natural amino acid. Another big advantage is prevent clot formation. Glycine is used by many hematologists to keep the blood unclotted. If you will take 10 ml blood and you put 1 ml glycine, blood will not coagulate. They use to preserve the blood. So, what is the advantage? If you are doing operative hysteroscopy and suppose you have bleeding, and if blood coagulate, you are in trouble, because your channel will get blocked. Which channel? Outer sheath. Outer sheath has very small openings. You can see this outer sheath has very small openings, and that much small openings here can easily block. So, after that you have to remove the entire outer sheath to clean it. But under glycine, this blood bleeding will not clot, so it can be easily exit. Another big advantage, it inhibits ionization. It does not allow electrolysis to happen, and whatever current you are using, that will be available for tissue. By ionization, it will not go disperse to the lateral wall. So, glycine is inhibiting ionization. But there is a very bad side effect, that is hyponatremia. What this glycine does, that it pushes the sodium through the loop of Henle of the kidney, and eventually there is a risk of hyponatremia. It is a big problem. And urologists, they suffer a lot, and it is called TURP syndrome. This is called TURP syndrome. It is a rare but potentially serious risk associated with the TURP. This occurs when too much of fluid is used around the prostate using this, and it is very big problem. Why it happened? Why it happened? It happened due to hyponatremic state. This happened due to hyponatremic state. It seems hyponatremic state, because glycine will put the sodium out. And problem with this patient is, prostate patient, is that they are elderly. Your patients are mostly young, because hysteroscopy is rarely performed in very elderly patient. Your patients are mostly infertility, so they are young, so they can tolerate little fluctuation in sodium. But a prostate is mostly after 60, 70. Prostate patients are 70, 80, 90 age. So they can create a problem and they die, rare, but serious. So, one of the most important thing is to prevention. How to prevent hyponatremia? First prevention is, the time should not be more than 1 hour, and fluid deficit should be calculated. Like, suppose this is uterus, and here is the uterine muscles, and this you have myoma, and you are doing resection, and you are resecting like that, like this, like that, like this, like that, and as soon as you have reached to the surface, you should stop, and that much you should take out. Remaining, automatically call the patient after a few weeks, it will be pushed into, remaining will automatically pushed into the cavity. And you should do the multiple steps, not in one session, multiple sessions you should do. So suppose you are doing procedure and 1 hour is over, then you should not be continuing for 3-4 hours. To prevent more time, more absorption of the glycine, and more absorption, more chances of more than 1 liter glycine, suppose it is absorbed, patient will go to hyponatremia. So, quicker surgery, and if it is not possible to do in one sitting, you may ask patient that 2-3 sitting will be required. Fluid deficit should be calculated. Suppose you have used 600 ml fluid, 3 liter bottles are available of glycine. If 2 bottles are used and once it is coming out only 4 liter has come, that means 2 liter is lost, deficit. Now where it can be lost? One, it can go in the abdominal cavity also through the tube, that you will see by laparoscope suction. थोड़ा सा glycine का bottle भिजवा देना और Y channel. So another, that it may go intravasation, means vessels. And third is leak going to table, going to the floor. That's why leak is not good, because it will be uncounted. How can it be? You have to wipe out all the fluid into floor and just collect in a bucket and then measure. So you should be careful that fluid deficit, if it is more, you should be careful, you should stop the surgery. Second way is that pressure should never go more than 180 millimeter of mercury. More pressure means more intravasation, because pressure will push the fluid into the vessels, more intravasation. Excessive pressure should be avoided. That's why you should use some pump. Some people, they just put a BP cuff and then do it. It's not good. You should use some device made for that purpose. Blindly fluid should not be given pressure. Some people, what they do, they wrap one BP cuff around the bottle and they pump the BP cuff, and then BP cuff can maximum show you 220, after that it is uncounted. And some people, they put a needle into the bottle and they pump the air into the bottle. Got my point, what I mean to say? And then sometime while doing, fluid is finished, and due to that air in the pump, air is entered, and that may create air embolism. Dangerous. So these things shortcuts should not be done. Another, outer circular layer should not be breached. Endometrium has a different layers, and those layers should be taken care of. These are the layers of endometrium. We can see this is called functional endometrium. That functional endometrium is 3 to 9 mm, which always proliferate, and then in menstrual cycle it is shaded out. This is called functional endometrium. After that you have internal longitudinal layer. Why it is called internal? Because it is towards the cavity. So anatomically it is internal. It is like a rectus sheath, it is looking like a white sheath. And then you have an outer circular layer. And you should not breach the outer circular layer. If you will breach the outer circular layer, you will enter into venous plexus. And then serious bleeding is started. And once the bleeding is started, what you will do? You will increase the pressure to stop the bleeding. And this venous plexus will now started taking the intravasation. And excessive fluid will enter, just like IV fluid, under pressure you are putting into the vein, because this venous plexus is now opened. So this is important, that this venous plexus should never be opened. and that should be kept in mind. So, this is the last one, third. Outer circular layer should not be breached. Time should not be more than 1 hour. Fluid deficit should be calculated. Pressure should not be high, and we should not dig the myoma out. Digging out is not allowed in hysteroscopy. Digging out means you should only try to shave it up to the layers, up to the surface. We are not supposed to dig it out. That is why all the myoma which is more than 4 centimeter in the size, with more than 4 centimeter intramural extension, laparoscopy is better, hysteroscopy is not good. All the myoma, all the recent literatures, they are not recommending hysteroscopy. So, if you will type here laparoscopy instead of hysteroscopy for submucous myoma, then all the recent literatures, comparison of hysteroscopic and laparoscopic myomectomy, laparoscopy instead of hysteroscopy, indication of curative hysteroscopy, in all the literatures, large submucous myoma, all of them they recommend laparoscopy. This is a Springer, and you go to conclusion, then you will see that all the randomized trial recent studies, they are favoring laparoscopy instead of hysteroscopy. So, we believe that the experienced laparoscopic surgeon skilled in endoscopic suturing achieving uterine closure is possible even in difficult condition. Hence, laparoscopic myomectomy is better treatment option for patient with submucous fibroid more than 5 centimeter with more than 50% intramural extension. Prevention. Now, coming to the treatment. If suppose it has already occurred, then what you will do? If already occurred, then immediate treatment is must. You can see here, this is the bottle of the glycine, this comes in 3 liter bottle here. This is the glycine, and this is 1.5% glycine. This is 1.5% glycine. Some people they use 3% also, but 1.5% is better, safer. And this is called Y channel. In this Y channel, you have 2 channels. See here, it has 2 channels. That is why it is called Y. One will go in one bottle, another will go in another bottle. And there is a lock here. It is locked. And one is open. And you know, before this one get completely empty, you should lock it and open this one. You got it? And after that, change this bottle. So that even a single drop of air should not enter. This is Y channel. And this end will go to the bottle, 2 bottles, and this is end has a lever lock which you will attach to the tubing of inner sheath. Inner sheath tubing, it will attach like this here. This is in the tubing, it is attached. So, this Y channel, don't use just simple, IV set. If you don't have Y, IV set will take all the pressure out, because caliber is so small that it will never build the pressure in the uterus, because it will destroy all your pressure. Lumen is not sufficient out to give the fluid pressure. So, this Y channel is necessary. Now, if you have done the hysteroscopy, then post-operatively you should never tell your nurse to give any sedative. Because the first sign of the hyponatremia is within 1 hour early hyponatremia creates confusion and delirium. This is the first sign. Even for TURP syndrome this happens first after prostate. Confusion and delirium. You did hysteroscopy today 4 p.m. and you took 2 hour time, 6 p.m. you have finished your procedure. During surgery, hyponatremia will not happen. Do you know why? It takes time. Post-operatively it happens. And post-operatively once patient is in the ward, patient will get confusion. Means she wants to remove her IV set. She wants to sit forcefully. She says that I want to go to washroom, this, that. Where I am, who are you, like this. That is confusion state, delirium state. This is the first sign of hyponatremia. After that, patient attendant will call the nurses, call the RMO. RMO will think that patient is troublesome patient. So they say, isko sedate kar do. Just sedate the patient. She is removing the Foley, removing the IV set. And more you will try to, capacitate the patient, you will try the hand, then more. A stupid patient has this big problem that you should not give a lot of force. If you will apply more force, to the violent they will become. They will more resist, more force. So after that it will be sedated, only option. Because she is not allowing any IV to, she is not sleeping at bed, she is trying to run away. Once it is sedated, after that patient will get in second hour cerebral edema, convulsion and unconscious. Patient is unconscious. And RMO is thinking patient is sleeping. I have given the diazepam, Fortwin Finargan, patient is sleeping. And then there may be death. So as soon as the first sign of the hyponatremia starts, immediately electrolyte should be seen, better ABG, arterial blood gas analysis. And if you see that sodium concentration decreases, immediately you should start the sodium. But remember that correction of the sodium, faster correction is more dangerous. So very slow correction, hypertonic saline has to be given. Very slow. Hypertonic means 3%. Normal saline will not work. So your team should know this. Your nurses, your RMO should know this, then they will not allow first stage to go to the second stage. Because mostly it is not aware of the things, how it works. And they consider this as a simple post-operative course of the patient. It is not simple, it is due to the syndrome that is called TURP syndrome. Another way of controlling these problems that you can buy some good machine like Endomet by Starch and Olympus is making hysteroflator. This is a hysteroscopic fluid insufflator. This will take care of the fluid and the pressure. Hysteroscopic fluid insufflator. Another way is that you can buy in this fluid insufflator, input and exit both will be controlled, gas and fluid both you can use, CO2 also and fluid also. And at the end of the procedure, it will give you fluid deficit. Another way, you should buy the advanced machine. During the laparoscopic dissection technique lecture, I have told you that any generator, if you have a very high frequency, then bipolar also started cutting. So you can buy Versa point. Versa point is made by Gynecare. Gynecare is a division of Ethicon. They are bipolar receptor generator. So if you will use it, you have to use normal saline that is compatible with the life. You don't have to use glycine. Monopolar we cannot use with the normal saline, because all the current normal saline will get out. Your current for tissue will be 0, because it will not allow it to go to the tissue, it will allow you to go to the uterine wall everywhere, because normal saline is very good conductor of electricity. So either you buy Versa point, or there are many other bipolar generators, like if you use this force triad. Force triad is a machine which has ligation also in between, and it has a underwater cutting also. This is called force triad. They have high frequency, and bipolar also will do. And if you are using bipolar resection generator, then you have to use normal saline, because it has 2 electrodes, and normal saline is necessary to travel the current in between these two. If you are using Versa point, then you cannot use glycine. It is not like that it is optional, you must use normal saline, so that current will travel in between the 2 jaws. So any company bipolar underwater generator you have to use. बोल दो करने के लिए, तो तुम जान नहीं रहे हो, क्यों दिमाग खराब कर रहे हो? So this is how you will do it. So this is how you will perform, and this is how you will put it here, and this is called Versa point. This is a bipolar hysteroscopic generator. Now you will put a speculum and you will dilate it. If you want to do under local, then you inject some xylocaine around, and after that up to 5 number of Hager dilator you are allowed to dilate if you are doing diagnostic, and up to 9 number of Hager dilator you have to start dilating if you are using operative dilatation. And that is why mesoprost and other things should be given, because if it is tight you have a big problem and it cannot dilate, you will bleed, and after that blood is the biggest enemy of hysteroscopy. Your vision is lost, because red color absorb all the light. So very good dilatation, careful dilatation is required. After that you put your fluid tip and put the hysteroscope at the tip. Remember, never ever attach the input in the output channel. If accidentally I will attach input here in outer channel, then fluid will started going by the side. Am I right? And after that you are in big trouble. Why? That this outer channel is closed by the cervical wall, and now you don't have distension. If you put at input channel, then it will go by the tip. You got my point? By the tip. Input channel is always opening by the tip. So you know cervix dilated last. First fluid has to go into the uterine cavity. After that it should open internal os, and then cervix dilates, cervical canal opens. So you should keep patience. Keep your tip at the tip, so that jet will be, fluid will be at the tip. It will go first in the cavity, then wait couple of minutes, and then slowly see the cervix is opening, and here it is now opened. It takes time fluid to go. After that, this is internal os. Under vision you will enter. Initially fluid will be dirty. So if you have a double channel, open the exit channel, it will wash out the cavity. If you have a single channel, then detach the input and let the fluid come out from the same channel. Or if it is loose, it is already leaking. Within few seconds, it will become clean, like this. It is clean, because fresh fluid will come, dirty fluid comes out. After that, turn the right light cable left or right, and you will see the ostia. Once the ostia is visible, then take it out and again go to the other side, you will see other ostia. Here, this is fundus, and here is the other ostia, and this is fundus. And here you have a texture gradient. Texture brighter means nearer, darker means deeper. Beginners, they diagnose a lot of polyp, because even a small clot or a small unshaded endometrial flakes, for them it looks like polyp. So what to do? Open the exit channel, and if it is polyp, it will be stable. If it is endometrial flake, it will move like a flag, like this. See here, this all polyp is now endometrial flakes, because due to turbulence of the fluid, it will start like a flag, it will start like a moving. So even a small blood clot or a small, because when you go too near to the structure, magnification increases, and you see, oh, polyp, this polyp, this polyp. No polyp. It is just the clots. A red color clots look like polyp. So be careful to diagnose a lot of polyp in beginning. And this is fundus. You can see this uterus is little like arcuate, little arcuate uterus. This is the fundus, and this is arcuate uterus. This is texture. Brighter means nearer. This is internal os, and this was a normal uterine. This is a normal variation. Arcuate is not always pathological. This is internal os, and then you come out. Now I will show you some of the slides for the diagnostic hysteroscopy, how it looks like. This is a case of endometrial, real endometrial polyp, which look like a tongue-like or finger-like or cactus leaf-like projection. This is endometrial polyp. This is atypical endometrial hyperplasia, adenomatous endometrial hyperplasia. This is endometrial carcinoma. For confirmation, you have to take a biopsy. This is submucous myoma. How many myomas are there? 4 myomas are there. This is 1, this is 2, this is 3, this is 4. Probably this also, but it is doubtful. So 4 are correct. This is nullipedasomen. This is versoscope, that's why the vision is small. And going inside, this is internal os, and this is submucous myoma. You will look for the ostia. This ostia is okay, this is fine. This ostia is doubtful, you will enter and try to go in between the gap of this gap and enter by telescope and try to go near the ostia. If by hysteroscopy also you can find out tube is open or not. Do you know how? If you will go near here, see the fluid is moving. Do you know if you open the bathtub stopper, you might have seen that there is a wheel of water over the bathtub. So if fluid is leaking, then a wheel of water here, see, that means this is the ostia, and this ostia is open. Otherwise it will be stagnant. You will not see the flakes moving round. So this way you can diagnose the submucous myoma. This is resection of the submucous myoma by loop electrode. Endometrial polyp. Forgotten IUCD. Here which instrument, which sheath you have to use? 4-channel, yes. And this is what? Grasper. This grasper will catch the thread of the IUCD and everything should come out. Everything together will pull out. This is very common because thread of the IUCD breaks and then it migrates deeper. So you have to remove by resectoscope will never remove it. Single channel will never remove it. You must need multiple channel. 4-channel sheath is required to remove it. This is intrauterine adhesion. You can see this is intrauterine adhesion. This is also important. This you should take care. This is intrauterine adhesion. This is TCRA, transcervical resection of endometrium. This is used for AUB, or previously AUB was called as DUB. So you will cut the functional endometrium just like how you are scooping your ice cream from the channel, and you will see white rectus sheath like structure, that is internal longitudinal layer, and you will stop further resection. Here you are cutting and you will stop at this level, that is, and you see resection is going on. Only 30% success rate is there, so it's basically obsolete procedure. Because nowadays therma choice and balloon ablation generally, Marina generally, TCR is not popular, but some gynecologists are still doing it. Asherman syndrome, here you will use cold seizures. Here also you need which channel? 4-channel, not the current. This is all 4-channel. And you will go and you will cut with the small pieces. These surgeries should always be performed under the laparoscopic guidance, so that you will not do perforation. And if you perforate, immediately you know, and you can repair. You can take a bite, you can repair, and at least bowel and rectum you will never perforate. Because sometime in Asherman what happened, that this is the cervix and you have a complete adhesion like that, fully, and you are making a false passage, or yahan se nikal jayenge, you will come out. False passage you will make, because your wish is to see a cavity. That's why you are cutting. and instead of a small cavity you will enter into large cavity, means you enter into abdomen. So always remember, if you are cutting like that and suddenly your vision is lost, then pack up. Ho gaya. Bas take out. That means you have perforated. If you are doing laparoscopy, then it's okay. Otherwise you are doing it and suddenly it is collapsed. That means your pressure is lost. Why pressure is lost? Fluid has leaked to the abdomen, and then you should not further continue. If you further continue, you will do blunder, because you can perforate the bowel, you can make a big perforation and there will be a big problem. So that is careful. And this is a large cavity now, and you will enter. So under laparoscopic guidance, sometimes you can see trans illumination. You will touch the light with the fundus and you can see trans illumination also. So that's why it's good. And cold seizures, current should be avoided, because current will do more readhesions because of collateral damage. And after cutting this, you should put a IUCD, so that further adhesion. Some people they use, see now cavity is there, good cavity is there. Some people they use a steroid local. That is up to you. It is double sword. It is beneficial also, it is risky also, because it can create infection chances, but it will decrease the inflammation and readhesion. So it is up to you what you want to use. Some people after cutting the asserman, they put one Foley's catheter. Now, you must try to identify the phase of the endometrium. Do you know, in menstrual phase you will not do. It is contraindicated to do hysteroscopy. Why? Day 1 to 4 you have completely red color. Red color will absorb all your light. Surface is very irregular. And there is no thickness, 0 thickness or 1 millimeter thickness. Gland is absent, there are no notches, no vessel will be visible, because vessels are eroding. Best phase is proliferative phase to do hysteroscopy, that is 5 to 14 days. Here, color of the endometrium will be pink, see here, this is proliferative phase. Surface will be smooth, no endometrial flakes will be there, because it has not generated yet. Thickness will be only 2 to 5 mm. There will be white dots, see here white dots. These are white dots. Notch will be hemorrhagic and very thin, these are vessels, very thin vessels. In between the white dot, thin vessels are there. This is the best time to do hysteroscopy. After that, early luteal phase, that is 14 to 21 days. In this there will be white color, wavy appearance, just like on the sand in the desert. Due to the flow of air, it becomes wavy. This is wavy appearance. Thickness is more than 6 millimeter. Glands will be prominent. Notch will be serous. Vessels will be absent. No red vessels you will see, because vessels are hidden in the endometrium proliferation. After that, late luteal stage, this is late luteal stage. It will be also white color, same like early luteal, but spongy, no wavy. It will look like a sponge, thicker than 7 mm. Glands are absent, notch is serous and vessels are absent. This phase is the worst phase to do. In this you should never do hysteroscopy, because it is just about to shed. And some of the endometrial flakes can plug into the ostia. And your tubal patency test also will come bad. So this is the best time to do hysteroscopy. That is proliferative phase, 5 to 14 days. How you will know? White dots, thin vessel and a smooth surface. These three things at least remember: white vessel, white dots, thin vessel and a smooth surface. This is proliferative phase. This is normal endometrial lining, how normal looks like. This is normal. Here is fibroid. This is polyp. This is Asherman. This is metroplasty, septum resection, and this is unhealthy endometrium. So these are the things which you should try to look for. This is atrophic endometrium. You can see all the basal layer is lost. You have to do a lot of hormonal treatment to regenerate endometrial linings. Atrophic. This is early atrophic. Just started. Good to treat. This is spongy. These are spongy phase. This is early tuberculosis. This is late tuberculosis. Cheesy appearance, creamy appearance, and this laparoscopically also you will find these type of tubercles over the bladder, over the broad ligament, over the uterus, over the bowel hair. So you will take a biopsy forceps and take the biopsy of those endometrium. This is important. This is necessary to keep in mind. This is early endometrium, you should try to take care of. Tuberculosis. This is also tuberculosis, early tuberculosis. This is very bad late tuberculosis. You can see entire cheesy appearance. This is very bad cases of infertility. This is also same little close up. This is the same picture, here it is close up. Sometime it won't be possible to take biopsy by laparoscopy in those cases. Then we use laparoscopic biopsy forceps to take it. By going and take a punch biopsy, you have a laparoscopic biopsy. After hysteroscopy already you have 5 mm opening, so straight you put a laparoscopic biopsy forceps and take a bite. Then it will take these cheesy better. How to do? I will tell them to bring it. This is also tuberculosis. This is retained product of conception. Different type. Sometime endometrial vascular atrophy. You know, in your member area there are 2-3 albums. थोड़ा सा बोलना laparoscopic biopsy forceps ले आएगा. Endometrial vascular, you know, in your member area there are 3 hysteroscopic albums. You should download those albums and you should try to remember all the abnormal anatomy, so that when your hysteroscopy you will find it out, then you will immediately diagnose, oh, this is I have seen in the album, it is looking like a same, because your eye can only see which your brain knows, isn't it? Without visual interpretation we cannot do anything in this world. Image is important for human. So this is there. This is also endometrial vascular atrophy, different cases. This is osseous metaplasia. It looks like a fetal bone. I told you, if this type of fetal bone like thing visible, be careful to give any report. Send for histopathology, let the histopathologist decide. I already told you one story, I don't know I have told you or not, that there was one case in which gynecologist has given a report of fetal bone And post-operatively, patient was divorced by the husband because she was never pregnant after marriage. So husband has a doubt that maybe she was pregnant before surgery, before marriage. So after that, court case was there, and then the opposite lawyer has asked the histopathology report and the video. So video recording is must, because they have given the claim that it may be osseous metaplasia. It is not necessary to have a bone, it looks like same. So leave it for pathologists, don't give this type of report to the patient. This is also osseous metaplasia. Once you take it out, it looks like completely like a bone. It converts into a bone, these type of cases, and look like a cartilage or some other, like this type of bone here. This is submucous myoma. This is what? Hydathiform mole. This is hydathiform mole. This is also retained concept of conception product. These are also late conception product retained. Some are calcifying, some are fibrotic. Many a time you have to do diagnostic laparoscopy with diagnostic hysteroscopy with diagnostic falloposcopy. You need 3 camera, 3 monitor. One will be in the abdomen, another in the uterus, and third in the tube. So here the guide wire is going, and by laparoscope you will put this guide wire under vision. Guide wire has 2 ends, one is soft end, another is hard end. This is soft end, always soft end has to be introduced. Never ever try to accidentally put the hard end. This is the soft end of the guide wire and it is introduced. After that, this guide wire is out, then you will put falloposcope. So this is now falloposcope going. This is the light of falloposcope. See, can you see that? This is the light of falloposcope. Falloposcope थोड़ा सा बोला guide wire और ureteric catheter ले आएगा. This is the falloposcope here. This falloposcope is very important in the developed country because of increasing number of the female who smoke. Because their tube will come patent completely. But it is a lead pipe like patent. They don't have cilia. Because smoking kills the cilia everywhere, not only in the chest, not in the trachea, not in bronchiole, it will kill the cilia of everywhere. So cilia is dead. If cilia is dead, it will not do chemotaxis to bring the egg and sperm to fertilize in the tube. So they have infertility. But tubes are open. Do you know, in the tubal patency there will be a lot of free spillage. You will put a lot of free spillage because no resistance due to no cilia. So falloposcopy is required to see the cilia, and then proper treatment, quitting the smoking, and these things are required. So almost you can rule out almost all the tubal causes of infertility if you will do laparoscopy, hysteroscopy and falloposcopy together. Then you can rule out almost all the tubal causes of infertility, and some therapeutic also can be done. Especially if the proximal tubal obstruction or distal femoral adhesions, you can do adhesiolysis, and by the Cook's system you can open the proximal. So you need 3 camera. This is bicornuate uterus. By hysteroscopy and HSG, it is looking like a septate. Hysteroscopic correlation is important. This looks like a subserous myoma by laparoscopy. MRI also showing subserous, but after putting it was having the submucous extension. This is ultrasound showing submucous myoma. This is HSG showing same submucous myoma, and this is hysteroscopy showing same submucous myoma. All three same patient. This is ultrasound, this is HSG, this is hysteroscopy. In hysteroscopy, your right is patient left. This is endometrial carcinoma. We can see irregular linings are there. This is endometrial carcinoma. This is the laparoscopic, I told you, biopsy forceps. If you see here, it has a tooth inside. इसमें एक दांत होता है अंदर. If you see by monitor थोड़ा close up करो तो there is a tooth there. And tip is a smooth, completely a smooth. So if you will see here, अंदर एक tooth दिखेगा. Here, ये दिख रहा है? Here, there is a needle inside. Here, this one. Did you see that? This one. So there is a tooth. So what you do, if you have already laparoscope, then go with the cervix, then touch the fundus and take a bite, and after only take a bite and not pull. इसको पकड़ लो बाबू. And then you just rotate it, ऐसे rotate करें. And once you rotate it, then it is already taken. And you open, and then here you have a biopsy tissue available. And due to this needle, it won't come out. So it will take a good, because hysteroscopic biopsy forceps is so thin that it won't be sufficient for tuberculosis. Your pathologist will give insufficient tissue. You got my point? So go by this, and this is blunt, so it will not harm. It is blunt completely. So after going and touching, open, catch and rotate, and then pull. This is the guide wire, and this is the ureteric catheter. You can use it for chromotubation. Remember, guide wire must be used very carefully, that it has two types, two ends. One end is very bad end, this end. If you will press it, it will prick. Another end is very smooth. See, I am pricking it, nothing will happen. It is not harming at all. I am trying to prick but nothing happens. It is impossible to damage. It is, see, it is not, even it will not perforate, nothing. It is very blunt and soft. But this end, if you will do, it will perforate the tube and come out. This is very hard. So accidentally never put this end inside the tube. And over the, how to do this ureteric catheter, you will put this soft end inside this catheter. And then first you should put this guide wire. Do you know, if you don't have this infrared ureteric catheter or ICG, you can use this ureteric catheter also to prevent injury of the ureter into the hysterectomy. And one end will be outside, and this is not expensive. See, this is the guide wire will go first, and then you will push the catheter. This is soft end. And then other end will be outside the vagina, so after surgery directly pull it. DJ stent should not be used for hysteroscopy. You should use the simple 6 French ureteric catheter. and same is used for chromotubation to inject the dye. Remember, HSG is not a very accurate technique of diagnosing the tubal block. In HSG, if tube comes blocked, then it has a 100% accuracy. Sorry, tube comes open, then it has a 100% value. But if in HSG tubes come blocked, then it doesn't have no value. It has 0 value. Am I right? If you are doing ट्यूबल पेटेंसी टेस्ट, मेरा पेन खो गया, क्या पता नीचे गिरा. If tubal patency test is showing, tubal patency test means what? Tubal patency test means you put HSG cannula and under laparoscopy you inject the dye in the cervix and you see it is coming out through the fimbria. That is called tubal patency. Nowadays we have started doing it with the ICG also. Indocyanine green. I will show you. This was first time in the world we have started. Nobody has done before. And we have a paper about that also. That tubal patency test with the ICG. Indocyanine green. This is we have done with the ICG. So, here this is the uterus and this is the tube either side, and here ovarian drilling also we have done, and see this is ICG coming out, and you will press, this is ICG mode, and as soon as you will press the ICG mode you will see this is all become green. Can you see that? And it will give you a lot of trans illumination. And another advantage is wherever you have a stricture you can find out exact place because it is trans illuminating the tube entire. This is ICG, indocyanine green, and all the caliber of the tube is visible. And now this is ovarian drilling with the PCOD needle. Here you go and drill. Only 4 poles should be drilled, only 40 watts should be used, only 4 seconds you should press, 4 millimeter it should enter, and 4 month time it takes for any hormonal effect to become corrected. So, this is ovarian drilling and with the tubal patency test, and this is PCOD needle which is doing it. So, this is tubal patency test. If tubal patency test is showing you it is open, it has 100% value. But if it is showing that tube is blocked, it has only 80% value. A still tube may be open. Then you have to do chromotubation. Chromotubation means catheter should be introduced into the tube and then inject the dye into the tube. Every tube, both the tubes separately. That if showing you tube is blocked, then it should be considered as a block. Got it? So, hysteroscopy is necessary to do that. Because most of the time HSG spasm is there, so no value. Even in the tubal patency, half of your this is leaking outside because of over dilatation and not fixing, or sometimes over fixation of the tip of the cannula. But chromotubation, directly under vision of hysteroscopy, you are putting a catheter in the ostia and injecting the dye into the ostia, that has a value. So, here this is the HSG is done and this is the endometrial carcinoma. This is the hysteroscopic finding of same endometrial carcinoma, and this is the resected uterus out. Uterus is taken out, after hysterectomy it was, incision was given to see this carcinoma. Now coming to operative hysteroscopy. Up to here we have considered diagnostic, now operative. In many situations, operative hysteroscopy is an alternative of hysterectomy. If you are good in operative hysteroscopy, many of hysterectomy you can avoid, unnecessary hysterectomy. Topographic anatomy, this is the uterine cavity, this is internal os, this is external os. These are anatomy of endometrium, already I have discussed before, functional endometrium, internal longitudinal layer, outer circular layer and venous plexus. Anatomy of uterus. Uterus is a solid organ which is surrounded by many structures and the ligaments. Normal length is 7 to 8 centimeter. Width is 4 to 5 centimeter. It has 2 to 3 centimeter wall thickness of myometrial. Wall thickness of muscle is 2 to 3 centimeter. It has 350 to 80 gram is the normal weight of nulliparous uterus. Now, it has 3 parts. First part is called cervix, other part is corpus. Cervix is 2 to 3 centimeter, corpus is 3 to 5 centimeter and fundus is again 1 to 2 centimeter. Most difficult part is internal os to enter, because that has resistance and most of the time we confuse internal os with the fundus, and that is how we perforate the uterus, especially in the long cervix. So, most of the hysteroscopist gynecologists should be advised in the beginning to enter into the uterus with the 0-degree telescope, because 0-degree telescope will show you black hole. You are seeing a black hole. 30-degree will never show you black hole. 30-degree will show you the wall either side, because 30-degree telescope is a squint telescope. A squint people, they will talk to you, but you will think he is talking to someone else, because he will see here and look towards you. So, same way 30-degree has a problem, that if you are seeing the black hole, that does not guarantee that you are not perforating. If you are seeing the black hole, that means you are more likely perforating, because if you are seeing black hole, that means your telescope is going on the side. If you are going correct, you will not see the black hole. What you will see? Cervical wall canal. So, that is confusing. Even in the laparoscope, when you are, all our telescope in the lab is 30-degree, because 30-degree is always better for laparoscopy. But you might have seen when you are putting the laparoscope in the cannula, then wall is visible, cannula wall is visible, not the black hole. Have you noticed it? Cannula wall is visible, because cannula is straight. So, when you are putting this telescope, you will see wall, you will not see black hole. So, that is why it is better to use 0-degree. And after entering inside, keep the sheath there and change this 0-degree to 30-degree. But entry, beginners 0-degree. Only drawback, you have to buy one extra telescope, but it will make your life easy and entry better. So, this is 0-degree telescope, and 0-degree telescope, what are the 3 important things to learn about telescope is, one is diameter, second is optical axis, and third is number of rod lenses. Am I right? So, diameter will be 4 mm and optical axis 0-degree. 0-degree optical axis means longitudinal axis and field of vision is 0. 30-degree means longitudinal axis and field of vision is 30-degree. So, 0-degree telescope, see this is black hole, and you will see this like black hole only in 0-degree, 30-degree will not show you. And then slowly, and if black hole is visible, you are safe. See this black hole, because you know where are you going. and slowly this is 0 degree you will enter. Once you will come at the level of interloss, then with the 0 degree in normal uterus, both the ostia will be visible. In the middle of normal cervical canal, in the middle of the cervix is the maximum diameter, that is 3 to 10 mm. 3 mm in nulliparous, 10 mm in multiparous, but only in the middle. Once you go at interloss, again you have a constriction, and you will see both the ostia with the 0 degree in normal uterus. After that you will go in one side. If it is 0 degree, it will be difficult, 30 degree will be easy. And then you can see ostia here. This is the ostia. One ostia, and then again another ostia will be visible. If you are using 30 degree, then before putting the hysteroscope, you must do the bimanual examination to check the uterus is anteverted or uterus is retroverted. Because if uterus is anteverted, light cables should be kept down, and uterus is retroverted, light cables should be kept up. In the Johns Hopkins Hospital, they do 200 cases study, in which they did bimanual examination of different age group of the female in different time, and they have published one data that how much is anteverted, how much is retroverted. Less than 35 years of the age patient, in 200% this study was performed, and less than 35 years of the age patient, 90% of their uterus are anteverted. This is anteverted, 90%. And this is 90%. But after the age of 35, it started becoming retroverted, and then it will become difficult to introduce into the uterus. You may directly perforate it here, because if you are going with the 30 degree, you should keep the light cable up, otherwise you will enter into the abdomen. So according to the bimanual examination, you should decide how to enter with your hysteroscope, and 0 degree will be preferred compared to laparoscopy. Now we will discuss some of the operative cases. Like one of them is the myomectomy. As we know, there are 3 types of myoma: subserous, intramural, and submucous. Of course, subserous myoma is gold standard by laparoscope. Easily you can, even pedunculated, you can tie one knot and you can cut out. You don't need much suturing skill. Even if you don't repair the serosa, it will regenerate. This is easiest to perform. Subserous. Remember, all the myoma must originate from the muscle. After that, its fate is decided, that where it will be pushed by the uterus. If it is pushed to the serosa, it becomes subserous; pushed to the cavity, it becomes submucous, and it remains in the muscle, then intramural. But it always originates from muscle. That is why the name is myoma. This is intramural for laparoscopy, and this is submucous. Submucous myoma is also of 3 grades: grade 0, grade 1 and grade 2. Grade 0 is predominantly pedunculated intracavitary, 100% intracavitary. This is the best to perform by hysteroscopy. You can remove it in one session also. If it is grade 1, more than 50% in cavity, less than 50% in muscle. It can be performed, some of them in one session or two. Grade 2 is the worst. In this, more than 50% is in the muscle. In those cases, laparoscopy should be preferred, at least if it is more than 4 centimeter. And if you are doing hysteroscopy, you should do in multiple sittings, not in one. 2, 3, 4 sittings, patient. Sometime what happened that after de-roofing, patient condition become more worse, because she will started profusely bleeding. Am I right? Because we have de-roofed it, and then it is forced to bleed more. So be carefully, and that's why all the myomectomy cases, MRI must be performed. Myoma must be differentiated from the adenomyosis. Adenomyosis is the worst case to perform by minimal access surgery, because we don't have a tactile feedback, and you will land up in a big problem. This is submucous myoma. You will go and resect. It's easy. By loop electrode, here it's entering. These all videos are there in your member area. If you want, you can record, no problem. You can record, but it is there already. It is there. But record, no problem. And here, this is, you can go, and this is the myoma. So, first you have to do diagnostic to know the boundaries of the myoma, and this is loop electrode. Go distal to the myoma and hook, look and cook. You will catch it and zzz, cut. Again you go, again hook, zzz, cut. And you should have hand, eye and foot coordination. Both, not only hand, eye, your foot pedal also should be coordinated together. And you will keep on cutting in a small pieces. It looks big, but these are only 1 millimeter slice, because magnification is there. And once you reach to the surface, you will see the inner longitudinal layer and outer circular layer. And as soon as you reach, this is circular layer, then you stop. You should never try to dig it. This is the outer circular layer. You should stop. If you dig it further, bleeding has started. So you have to see texture gradient. If this texture is equal to surrounding texture, that means it is time to stop. What are the depth Q in laparoscopy? Relative size, linear parallax, motion parallax, occlusion, shadow, texture gradient, aerial gradient, these all are depth Q. But in hysteroscopy, you have only one depth Q, that is texture gradient. Why? Your azimuth angle is 0. Azimuth angle means angle between telescope and instrument is 0. Those are parallel. So always be careful that texture should never be more dark than the surrounding, otherwise you are digging, and then you will enter into venous plexus and bleeding has started. So this way resection has to be done. And if suppose 5%, 10% of myoma is still uncut, it will automatically degenerate and it will be pushed by the muscle. You don't have to worry about 100% to take out, and this is done. After that, leak evacuator and suck it out. This is again another myoma, anterior wall. This is anterior wall. Again you have to, CCD should never be rotated. CCD always should be down, and your resectoscope should be rotated, and here you will keep on doing resection. Similarly, hook, look and cook. During resection, always from darker to brighter, and always from distal to proximal. This is hook, look and cook. Small pieces will be taken and keep on slowly cutting. 80 to 120 watt current is required. If you have normal 400 watt ESU is required. Remember, if you are buying the simple electrosurgical generator, simple means only 1 lakh rupees like Eclipse or Jahangir, or this means cheaper Indian one, they have two type. One is 250 watt and one is 400 watt. For laparoscopy 250 watt is sufficient, because we need maximum 70-80 watt. But if you want underwater, then you have to buy 400 watt generator. If you have a 250 watt, if you go in the lab, in our lab all the generator is 250. If you see carefully, it is written 250 over the generator. I will show you. They will bring any generator, I will show you. It is written 250. And that will not work for hysteroscopy. You will be in trouble. So always you should use 400 watt generator. And then it is coming. And here it is slowly resecting and cutting the myoma. So hook, look and cook. Here also similar strategy is given, and you will keep on cutting small pieces. Now this is also another myoma. This is the resectoscope, how you will put it. बाबू एक 250 वाट का एक इलेक्ट्रोसर्जिकल जनरेटर ले आओ तो मेडी लैब का, and here you will put it. This is hysteroscopic morcelator. This is also available in the market, where you don't have to use current, directly you can morcelate it. So see, it will rotate and it will morcelate. It will cut mechanically, it is not using current. It is mechanically, it is grinding and sucking out, just like how we use morcelator, it is doing the case. This is hysteroscopic morcelator. But it is only for grade 0. You cannot use it for intramural extension. Now for septate uterus, there is one more hysteroscopic 250 watt generator. There is one more hysteroscopic generator, which is, I don't have video, so I will show you here. This is called MyoSure. This is MyoSure. This is hysteroscopic generator. This also is hysteroscopic morcelator. Of course, it is little expensive, but you can use. How it works? It will enter into and it will grind it like that. And it has a channel for camera, separate, same channel has camera here. And now you remove the obturator, and after removing the obturator, this is morcelator, which you will introduce. It all comes in one set. And then suppose this is myoma, you will see, and by the side of this there is a blade, by the side. And once you touch, it will rotate. And see, morcelating. In video it looks very good, but in reality it doesn't cut that much good. Do you know why? Because myomas are not always at the appropriate side. It may be in the fundus, or it may be at difficult places. So it is not very popular. But if you have no problem with the money, you can buy it. Some cases it works very nice. Not in all cases, but in some of the cases. So it is cutting directly like that. And you can morcelate it. So this is called MyoSure. This is hysteroscopic morcelator, in which in situ it will morcelate. You don't have to do any current. And it has two type of movement. One is to and fro, another is circular. So this is possible. Here I was showing you here, this is the generator. You will see it is written here 250 watt. यहाँ पे लिखा होगा ये here. Can you see that? What is written? 250. This is the new. अभी पन्नी वगैरह लगाई हुआ है. This is 250 watt. So this will only work for laparoscopy. This will not work for. You need 400 watt minimum, and that means underwater cutting. Otherwise, it won't work. Because underwater amount of wattage is required more. But this will be cheaper. This 250 watt, if Indian you will buy, it will cost you 50,000-60,000 rupees only. Now coming to septate uterus. In septate uterus, you can do metroplasty. Laparoscopically, you will see one white band there. Whitish band in the middle. This is a straight knife, and once you will use it, it will start cutting in the middle. Of course, in septate we cannot go distal to proximal. You have to go proximal to distal, towards the fundus. So you have to be careful. It is right now it is dark either side, but once you keep on cutting small bites, as soon as you reach to the fundus, you will see texture changes. And once the texture become bright, you should stop. Brighter is nearer, darker is deeper. Now see, texture is coming nearer, and that means it's time to, left side is almost over. Because if you are too enthusiastic, from a small cavity you will enter into large cavity. There is one Collins knife that also do very good metroplasty, because here you can see there is a whitish band. Laparoscopically you will see there is a white band in the middle, this band. So that is a very diagnostic of laparoscopy. That will differentiate from the adhesion with the septate uterus. See this band. In septate uterus there will be white band. Adhesion there will be no white band, because septate uterus is congenital since birth, and this whitish band will be visible. This patient ovary is good, tube is good, everything is good. Only problem is with the septa. So here this is hysteroscopy. This is the ostia. This is the right ostia, and here is the septa, then you have a left ostia. So you will check the ostia either side, and after that you will take it out and you will take the Collins knife. Collins knife is very good. That is like a L hook which is we use in laparoscopy, that is called Collins knife. And this is like a L shape, and this is called Collins knife. And then you will keep on cutting in the middle. Near the cervix it will be very thin, because septas are like that. Near the cervix it is thin, and near the fundus it is wider. So this is very thin, and this is either side is black. This is black. So you will keep on going proximal to distal. 1 millimeter in one time, very slow. Don't play big, very slow. And you will keep on cutting slow. A small bite will be taken. Once you reach near the fundus, then ask the second assistant, means second surgeon or your gynecologist or your nurse, to bring the fundus telescope near the fundus, and you will see trans illumination. That will guide you in metroplasty, and it will stop you perforating. That is very useful. That is why large operative procedure, hysteroscopy should be combined with the laparoscopy. So, this is slowly cutting. Here, once you reach near the fundus, you have to cut in steps, because it will be too thick for your Collins knife. So, you have to cut. See this light. This light was laparoscope. It will be visible later also, but I will show you here. It is cutting, and this is the trans illumination here. This is the light of the laparoscope. It will be more visible once we reach near the fundus. So, under laparoscopic guidance, hysteroscopy is very useful, and that gives you depth perception, and that helps you to prevent perforation, and in incidence of perforation, it helps you to repair. We can see texture is reaching, and either side small, these are the septa. Only in the middle you have to cut, you don't have to cut two places, because it is already under tension. As soon as you cut, it go apart, and at the end IUCD is must. But if you have damaged the uterus, never do IUCD, otherwise it will migrate into the abdomen. We have removed many cases where IUCD was in the abdomen, and it is cutting like that. Slowly you will do that. Here we can see this is cutting in steps, and this side is a septa, and again slowly you will cut. Here light, this is the light. This light is saying, don't come near to me, remain away from me. So, this side is over, now you will always cut other side where the light is not there. So, this way slowly this side is still dark. You can rotate this Collins knife any side, this side or that side, it can be rotated. So, now it is rotated to that side, and this side is still little bit required, and you can cut. So, this way now you can see this is laparoscopy again, and what is whitish band is gone. No more band which was present in the before, and it is more anteroposterior. Initially it was flat. In the beginning, if you will see, in the beginning it was looking like this, see, band, and at the end it is looking like a globular, and it looks like good. So, this way metroplasty is very rewarding surgery, and hysteroscopy under laparoscopic guidance can be performed. One very simple surgery is also very good by hysteroscopy, that is called hysteroscopic sterilization by SCO2. It is not very common in India. It has a polyester at the tip, is the polyester, white color polyester, and in the back you have the nitinol metal. Nitinol and titanium, these two metals are inert metal. It is like a spring of a ball pen. So, this part you will push into the tube, and this part will keep on dwelling into the cavity. So, this is cervical canal. Now, this is internal os, and now cavity, and here is the ostia. This is one ostia, this is another ostia. Now, this is the guide wire, and this part of the SO2 is polyester, which you will push it by pusher. There is a pusher. Push it into the tube and then hold the pusher and remove the guide wire. It will be dropped into the tube. Just like how you put double J stent, same way. And now guide wire is pulled out. Pusher is also pulled out. This is guide wire is coming out. And this part you can see like a spring of a ball pen here. This is like a spring of a ball pen. This is nitinol part here, which will remain into the cavity, dwelling in the cavity. Polyester part has gone into the tube. And again you will take the another and again you put the nitinol part inside. So that way you will perform, and this is the another tube you will enter. Polyester part inside the tube, guide wire will be pulled out, and that is all. Up to 21 days of the surgery, you have to give any alternative method of sterilization or complete abstinence, because it works by fibrosis, not by inflammation like a copper T. It works by fibrosis. This is the metal part. After 21 days, you should take a X-ray to make it sure that it is in position, and after that it is okay. Only it can be done in OPD. Only drawback of this procedure is it is completely irreversible procedure. There is no chance of even recanalization, because proximal fibrosis happen. So you cannot cut that part and recanalize also. Fallope ring, filthy clip, Hulka clip can be recanalized. So patient should be sure up to the point of absolute certainty that she doesn't want any baby. So
if this patient wants to get pregnant, let's say by IVF.
Yes, no, IVF also is not good, because you have to remove it. And removal is very challenging because of fibrosis. Keeping this metal part inside, you cannot implant. So that is why it is very bad. Now, that is why patient should be up to the point of absolute certainty. Now, there are few bipolar high frequency generators are available, that is called plasma sect and V sample. This is plasma sect. Do you know they are so high frequency that they cut very fantastic, and they use bipolar. They do not use glycine, they use normal saline. This is called plasma sect, and this is called V sample. Do you know it is just like a twin blade. If you will see very carefully, plasma V sample, plasma means frequency is very high. And you can see it is like a twin blade. There are two electrodes and a spark in between. There is a spark in between. These sparks are doing the, and normal saline is required for keeping this spark in between here. Just like a twin blade which you shave. And it evaporizes the tissue. So only drawback is you will not have the sufficient tissue for the histopathology, because it will, it will do the good evaporization of the tissue. So this is called V sample and plasma sect. Those are very expensive machine you can buy to make your surgery easy. Now let us discuss disadvantages and complication. One of the complication is trauma. Second complication is intravasation. Third complication rarely death. Trauma, intestinal perforation, bladder injury, rectal injury. Bowel is already adhered because of previous MTP or DNE, am I right? And you are doing septate uterus by seizures and you will perforate the bowel. Bladder very commonly perforated because anteriorly it is almost sitting over the bladder. Rectal injury, if there is already endometriosis and rectum is adhered with the uterus, perforate. Intravasation happens if you have a tuberculosis, if patient has hypoplastic uterus and excessive pressure of distension. You are using 200, 300, 400 millimeter mercury pressure because you don't have any machine, you are blindly irrigating the fluid. Death happens due to two factors. Immediate death happens due to vasovagal shock and embolism. And late death can happen due to peritonitis. Immediate death due to the excessive pressure, like 400 millimeter mercury, vasovagal shock and death can happen on the table itself, or air embolism. Late death means already patient has severe PID or there was endometrial infection and you did hysteroscopy, you have pushed all the infection in the peritoneum. And then peritonitis, bacteremia, septicemia happen or bowel perforate. If you will bowel perforate, patient will not die on the table. He will take 2, 3, 4 days to die. Am I right? Because first bacteremia, septicemia, peritonitis and then death. Late death is never due to perforation. Contraindication. Endometrial infection is absolute contraindication. Patient is coming in the OPD, you do diagnostic and you found that a lot of foul smelling discharge, greenish discharge, whitish discharge, don't do hysteroscopy. Put the patient in gram positive, gram negative, anaerobic as well as antifungal treatment for few weeks and then call for hysteroscopy. Because if you do it, you are pushing all the infection in the abdominal cavity because through the fimbria it will leak and all the infection go to under cavity and patient will have PID and bacteremia, septicemia, peritonitis. And if you are doing operative, then directly it will go to bloodstream because some fluid always go to bloodstream. Menstruation is a contraindication, of course, bad vision, more intravasation, more infection, and you will not have any methods of diagnosing the pathology, you will not have biopsy tissue also. Because shaded endometrium will take everything out. You don't have tuberculosis biopsy and this we cannot do. So it's a contraindication. Pregnancy is of course a contraindication. But there are few indications in pregnancy also. One is IUCD with the pregnancy. Although in the book it is written that you don't need to remove IUCD if patient get accidentally pregnant. Baby will come with the hand in the IUCD in the hand and show to the mother that what is this. So you may not need to remove. But some females are not comfortable with the IUCD, they are psychologically not feel good to continue pregnancy with the IUCD. So keeping the pregnancy intact, this is possible to remove IUCD. Although high chances of abortion will be there, but it is done. Another indication in pregnancy is in old time people were doing fetoscopy by hysteroscopy. Nowadays fetoscopy is almost obsolete because of 4D ultrasound, MRI and other good non-invasive techniques. So this is another indication in pregnancy is hydatiform mole together with the continued pregnancy, but it is rare. Next is pelvic irradiation or any cone biopsy or recent trauma. Like some malignancy irradiation was done over the uterus, then all the wall is weak due to the radiation trauma. Or suppose patient has myomectomy done, cesarean performed, or simple MTP someone has done, and patient comes to you, you have not done MTP, somewhere it was done. and it comes in your mind to see that retained concept of production or this that, you should think twice. Because during that evacuation of pregnancy, if she has traumatized the uterus myometrium, you are going to perforate it. Because it's already half perforated, pressure will increase, will flush, and you will be in trouble. So recent trauma, you should avoid doing hysteroscopy unless until you do under laparoscopic guidance. If you put a laparoscope, then it's okay, because already you see that it was not perforated or it is nicely healed. But then also after myomectomy and all, up to 3 months you are not allowed to do hysteroscopy. Like intramural myoma was there, and now you want to do hysteroscopy, immediate hysteroscopy will perforate it. So these are contraindication of hysteroscopy. So this was regarding the hysteroscopy. You have any question? That is very good question. That, it is double sword for that cases. If already you know that it is a carcinoma, then you should not do it. But sometimes it is used as a means of diagnosis also. Yes, but suppose you are having doubt that what is that, then it is done. It is indicated also. So, any other question? It depends what resection you have. If you have a normal resectoscope, you will use glycine. And if you have a plasma sect V sample or Versa point, Versa scope is a telescope, Versa point is a generator, then you will use normal saline. So it all completely depends. All can be used by bipolar also, by monopolar also. All the operative procedure can be done by bipolar also, monopolar also. So if you are using bipolar, you will use normal saline. If you are using monopolar, you will use glycine. But remember, all the plasma sect V sample Versa point will cost you approximately 15 lakh rupees. With the resectoscope instrument, and you are bound to buy now the electrode from Ethicon, Johnson & Johnson. Normal monopolar electrode costs you Indian 600-700 rupees. This bipolar resectoscope will cost you 3,000 rupees. From you are bound to buy now by Ethicon, because other company doesn't fit. Just like if you have bought one harmonic scalpel, then you are bound to buy the hand instrument from Ethicon, isn't it? If you buy Ligasior, you are not one-time customer, you are lifetime customer.